terms of the background, so how I came to study this particular medication is I have always been very interested in prevention. And one of the challenges in breast cancer prevention is that currently the medications and we have for prevention, most women really don't like to take them because they can have some side effects that they don't like hot flashes, and younger women or if older women, they can have issues with it can impact their bone density. They can have joint aches. And so when one of my research collaborators came up to me and said, I'm working with working with this company who's developing a drug that prevents hot flashes and bone and osteoporosis. So something that makes women feel better. And he's like, I wonder if it has any preventative properties. And I was like, wow, that's really exciting, to think that something that that actually makes women that's developed to make women feel better, like maybe it could have these additional benefits. So that's how I really got involved in the project. And, just as I mentioned, the drug itself, I won't talk about what company it comes from. The drug itself is FDA approved in the United States to treat hot flashes and osteoporosis. And it's been FDA approved for about 10 years. And it was originally developed to, as an alternative to combination estrogen and progesterone therapy, because of some of the concerns patients had with breast cancer risk and endometrial cancer risk, and et cetera. So that's how the drug came about. Anyway, a little bit about the study. So the type of study that we developed was a window of opportunity study. And we chose to study DCIS because DCIS is a non-obligate precursor of invasive breast cancer. So about 25 to 30% of women who have DCIS will go on to develop invasive breast cancer in the future. So we thought it was a good model for for this idea of, does our medications, conjugated estrogens and Bazedoxifene, or I call it BZA for short, does this medication, can it potentially prevent breast cancer? So we thought it was a good model for prevention. And the other nice thing about the model, the window of opportunity study and studying DCIS, is these women all undergo surgery, right? So they have a diagnostic biopsy and they'll have surgery. So you have tissue available at baseline and at surgery, and the patient doesn't have to have any additional biopsies. So that's, and that patient is, there is usually a window of time, like 3 to 4 weeks between between when the patient sees you and when they have surgery. So you have this great, time that you can use to study this medication. So, the other good thing about our model is that the other good thing about the DCIS model is, you can study both the epithelium and the stroma. And so this is one of the other areas that we're studying, so we, our primary goal of the study was to look at epithelial proliferation, if our medication could decrease epithelial proliferation. But there is also some preliminary data that suggests that it could also impact the stroma, and it could also be protective in the stroma. So we have the benefit of studying both the epithelium and the stroma with a DCIS model. So that's how we chose this particular model. So we recruited women, they took this medication for 3 to 5 weeks before surgery. And we had a variety of endpoints. Again, the primary endpoint was the proliferation, which we measured by protein expression of Ki67. We also looked at HER2 expression, which we're still analyzing. We looked at RNA sequencing to look at, expression profiling. We looked at quality of life, again, which is very important in the prevention setting. And then we still have some ongoing analysis with our stromal biomarkers through multiplex staining. So that's just a little bit about the study. The study, took 7 years to complete. We had some time. We had a little bit of delay with COVID, but it was from 2017 to 2024. And then, we had originally wanted to recruit 140 patients, and we got 141. So we were able to meet our target. Some patients, some patients drop out for various reasons. I think one of the bigger reasons was COVID, actually, with scheduling, patients getting, being sick and missing their window. And then, in terms of the data and analyzing our primary aim, so patients sometimes, we lose some patients because we don't have any tissue left after surgery. It's all removed at the core biopsy. So there was about, I would say about 19 patients didn't have tissue at their baseline or surgical biopsy for us to analyze. So we ultimately analyzed about 94 patients, and we found a statistically significant decrease in Ki67. Our p-value was 0.016, so it was very significant, and that. In terms of the absolute reduction, it was 4.5% reduction in Ki67. One of the other things, as I mentioned, we looked at quality of life, and so we looked at two different measures. One of them was this BEST questionnaire, which has been used for tamoxifen and aromatase inhibitors for many years to look at severity and frequency of endocrine therapy related symptoms, and we didn't find any difference between the groups, which I think is important. Now, it was a shorter intervention, right? So most of those studies, they look at quality of life over a 6-month period, but nonetheless, the medications, the medication patients can feel. The medication takes effect pretty quickly. Usually, they feel better within 1 to 2 weeks. So we thought we would see a signal of some kind during our intervention. So I think that that's an important thing, that there was not a difference in side effects between the two groups. And then we also looked at menopausal symptoms, because the intervention CE-BZA is approved for menopausal symptoms. So we wanted to see if patients would get better. And we didn't I see a difference in that group either. Again, intervention was short. There was a non-significant decrease in hot flashes. And, we still have to look at that data a little bit, in more detail, potentially looking at patients who just had hot flashes to see if they had a decrease in their hot flash symptoms, if that was significant. So I think those were really the two big key things, where it was the decrease in proliferation and the fact that it didn't impact quality of life.